Today we'll be discussing about petrositis. Petrositis is the inflammation of the rheumatized portion of the petrous part of the temporal bone. The complication of otitis media we regularly describe as petrosapicitis, that is, inflammation is spreading to the petrous apex. The petrous temporal bone is rheumatized in around 30 to 20% of the people. The air cells extend into the petrous pyramid in two different groups, anterior and posterior groups. The posterior group is in continuation with the mastoid and epitympanum, and they traverse around the semicircular canal into the base of the pyramid into the petrous apex. Anterior group of cells that is in continuation with the mesotympanum, hypotympanum, and protympanum go around the cochlea into the petrous apex. As part of the tympanomastoiditis, some amount of inflammation of the pneumatized petrous part of temporal bone will be there, which can resolve without any complication. But if the inflammation is persisting and the infection is continuing, there can be abscess formation and involvement of the cranial nerve in relation to the petrous apex. So there are two cranial nerves that is involved in the petrous apicitis. First is the abducer nerve. The abducer nerve traverses the Dorello's canal to reach the cavernous sinus. Dorello's canal is formed by the dural invagination at the petrocleval area. So it is an intradural space. The roof of the Dorello's canal is formed by a ligament known as Gruber's ligament or the petroclinoid ligament or the petrosphenoid ligament. So what happens is the lateral wall of the Dorello's canal is formed by the petrous apex. So the petrous apicitis cause inflammation in the Dorello's canal, and the abducer nerve is compressed in the Dorello's canal, causing lateral rectus palsy. You know that all the extraocular muscles are supplied by oculomotor nerve except SO4 and LR6, that is superior oblique, is supplied by the fourth cranial nerve, that is cochlear nerve, and lateral rectus is supplied by the sixth cranial nerve, that is abducer nerve. So abducer nerve involvement will cause lateral rectus palsy and diplopia for the patient. The next cranial nerve that is involved is a trigeminal nerve. And the trigeminal nerve and the trigeminal ganglion, known as a Gasserian ganglion, is present in the Meckel's cave. And the petrous apex is inferiorly related to the Meckel's cave. So, on petrous apicitis involves the trigeminal nerve, causing trigeminal neuralgia or retroorbital pain. So, there is a triad of three symptoms, that is retroorbital pain and lateral rectus palsy causing diplopia. The patient will have the ear discharge rotoria due to the otitis media. So, this triad is known as Gradenigo syndrome. So, remember Gradenigo syndrome, petrositis, and three P's: pain, retroorbital pain, purulent otorrhea, and palsy, lateral rectus palsy. Schutnitz have also described a condition of chronic petrositis in which there is persistent chronic inflammation of the petrous apex leading to newborn formation. This can also involve the labyrinth causing labyrinthitis and extend into the brain causing meningitis and other complications. So what is the management? We have to suspect involvement of the petrous apex if patient is coming with the retroorbital pain and lateral rectus palsy and otorrhea, purulent otorrhea. Sometimes all the three things may not be present. Either two of this is present. Also, you have to suspect a petrous apicitis. You can do an otoscopy examination to rule out any otitis media. HRCT temporal bone can be taken to assess the status of the bone and bony erosion and involvement of the mastoid and all that. MRI scan, MRI of the brain and temporal bone can also be done to assess the extent of the abscess or any intracranial complications. Along with it, blood workup, blood culture can also be done. LP, lumbar puncture, can also be done to rule out any meningitis or meningeal involvement. Treatment is IV antibiotics. Admission, high dose IV antibiotics, and also surgical management will be required. Complete mastoidectomy, sometimes radical mastoidectomy is required. I had a patient, 33-year-old male, who recovered just with the IV antibiotics. He didn't have any other comorbidities and he presented immediately. Only 1 week history is there, 1 week history of URA, ear pain, and then he suddenly developed the lateral rectus palsy. So he recovered immediately with IV antibiotics because he's young and he didn't, young immunocompetent person. But in certain cases, surgery has to be done to clear the abscess and clear the disease. Surgical approaches to petrous apex depends upon the location of the infection, the degree of pneumatization of the temporal bone, and also the status of hearing of the patient. So in patients with no hearing, already the labyrinthitis has happened, the hearing is fully gone. So in such patients, you can go for a translabyrinthine approach for the posterior group of cells and a transaortic or transcochlear approach for the anterior group of cells. To preserve the hearing, you have to go for a retrolabyrinthine approach for the posterior group of cells. and inferior to cochlear approach, infracochlear approach for the anterior group of cells.